Broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. Good afternoon and good evening. Thank you, everyone, for joining us and welcome to today's session. Today's talk is entitled Biostatistics and SARS Coronavirus 2, Research, Policymaking, and Communication. My name is Kelsey Brown. I am the medical writing manager at TransPerfect Life Sciences here in London, and it is my pleasure to be your moderator for today's session. Today's event will run for approximately 60 minutes, and that includes time for our Q&A session at the very end with our speakers, so that'll be about 15 minutes towards the end. This session is designed to be interactive, and it works best when you're involved, so please feel free to submit your questions and comments for our speaker by using the questions chat box in your control panel, and then we'll answer your questions during the Q&A session at the end. If you require assistance, just reach out to me at any time by messaging me in your control panel. And at this time, all participants are in listen-only mode. And please note, this session will be recorded and made available to you on the IDDI website for viewing within about 24 hours after the webinar is complete. This event is proudly hosted by the International Drug Development Institute, IDDI. IDDI is an expert center in biostatistical and integrated e-clinical services for pharmaceutical and biotechnology companies in several disease areas, including oncology and ophthalmology. IDDI optimizes the clinical development of drugs, biologics, and devices thanks to proven statistical expertise and operational excellence. Founded in 1991, IDDI is headquartered near Brussels, Belgium, with the U.S. Center of Operations in Raleigh, North Carolina in the United States. And today's speaker will be introduced by Mark Busey, Chief Scientific Officer at IDDI. So I'll hand it over to you, Mark.
Thank you, Kelsey. And it's a great privilege for me to introduce Geert Molenbergs, who's a longtime friend and also a very well-known statistician in Belgium. Geert was kind enough to send me his biography, and of course I've known him for a long time, so I discovered a lot of things I didn't know about him. And to be honest, if I had to do justice to his CV, I would probably take half an hour, and that wouldn't be good because I want him to speak for about an hour. So it's a real pleasure here to have you on this webinar. We are very privileged. Among the many things that you've done in your career, you've been a member, or you are a member of the Royal Academy of Medicine in Belgium. And also recently, as some of us know, you have been an advisor to the Belgian government, particularly for the COVID-19 epidemic. And you have been very active and very busy as well on control measures, measuring the occurrence of COVID-19, looking at different measures that can be taken to prevent it and to treat it. So I think this gives you a wonderful experience to talk about today, and we very much look forward to your talk on COVID-19 in Belgium. Thank you so much again for doing this for us.
Thank you very much, Kelsey and Mark, for the very nice introduction. I hope you can actually see my screen right now.
Yes, we can.
In which case, without further ado, I'll be happy to get going. So when we talk about the pandemic that hit the world early in 2020, we see curves and data like this. And a question that we often get from politicians, from the general public is, what number do you look at to follow the epidemic? And of course, it's like asking a pilot, what dial do you look at in the cockpit? What is the pilot going to say? Well, all of them, they're all important. And not only that, their interaction, how they fit together or not, is crucial to distinguish between a safe flight and one that is potentially in jeopardy. So let me, in the first part, briefly run over a number of quantities. And of course, I know that at least 100% of you know these quantities very well, because for better or for worse, wherever we are in the world, that is what our health institutions, our academics, our governments, our politicians look at. When we talk about Belgium, we can look at, for example, the curve of confirmed cases, and that means people with a test confirmed infection. And this is the curve really from the beginning of the pandemic, early March 2020, until very recently. The last 2 weeks are not part of the curve yet, but let's go back to the beginning. And then what we would see if we look at the curve is a relatively flat evolution, and then suddenly in the fall of 2020, this very large peak. Of course, this is not in line with reality. We had a very large peak also early in 2020, and that doesn't show. But of course, in Belgium, in Europe, in the United States, and in so many other places in the world, at the very beginning, it was just very difficult to confirm COVID unless it was really absolutely necessary. There was either a patient with a very critical condition or belonging to a risk group, for all we knew about what the risk groups were at the time. To put a perspective on that, in the first part of the pandemic, so in the first wave, and for us that is the spring of 2020, about 1 in 30, maybe even only 1 in 50 actual cases were confirmed by a test. And this had dramatically changed in the fall of 2020, when roughly 1/3 to perhaps, or maybe somewhere between 1/5 and 1/3 of the cases got confirmed. And that's why we have this distorted picture with, by the way, a very small elevation here in the summer season of 2020. And then a period where the curve is lifted from the ground for a longer period of time to touch down for a brief moment again in June of this year, to then show a rise again. So just to give an idea, Belgium is a country of 11.5 million people, more or less. If we look at the number of cases confirmed in 2020, we get to something like 650,000. In reality, it's much more likely that confirmed and unconfirmed cases taken together, we are kind of at 2.5 million for the year 2020. And for the current year to date, this should be somewhere between 600 and 700,000. The slide says roughly 500,000, but that was for the first part of the year, where we had our, as people call it, our third wave around Easter in 2021. At the second peak, so in the fall of 2020, just again to give an idea, it was estimated that roughly 250,000 people were active at any given day, so could infect others. If we look at all cases indeed, I just showed the confirmed cases. This is confirmed and non-confirmed cases taken together. We do see a very different picture indeed. A first peak in the fall, in the spring, a second peak in the fall, and a minor peak in the summer of 2020. But the major peaks are roughly equally tall. Now, you can ask yourself the question, how do you know that? Well, we're statisticians, we don't know, but this can be estimated from models where, again, all of the data available with all their imperfections are taken together. And therefore, an estimate can be made of all cases or the total number, or as we sometimes call it, the dark number. If we look into 2021, we see that the total number of cases is estimated at a relatively low level compared to the first and the second peak. And what you see here in the summer in this graph is not completely trustworthy. That was based on prediction rather than actual modeling. Positivity, at first sight, it's if you put yourself in the shoes of 2019, it would maybe be a little strange to then say, well, if in the next pandemic we will take the positivity ratio as a very important measure. It turns out that it actually is. If you look at the previous graph on all cases and the positivity, they kind of nicely correspond to each other, because it is well known right now, in spite of all the misinformation there exists around that, if the positivity goes up, then the pandemic is spreading and we have less and less control over it. During the winter peak in the United States, for example, there were states where this went up to 60–70%. That means 60 to 70% of all tests turn out to be positive on a given day or in a given week. Whereas in Belgium, we rose to roughly twice 1/3 of the cases positive, which is way too high. We have a short period here in June 2020 and incidentally in June 2021, the only periods where it happened, where the positivity went down to 1% or even just a little below. Many countries, many states almost never achieved that, although there are countries also in Europe where that has been the case for a longer period of time. Example, Denmark, for example, where for a long period of time, the positivity has been ranging between 0.5%, 0.7%, which means that there is a very broad testing policy and therefore you really put the light very strongly on the epidemic. You have things well under control. If that number rises, it means there is more and more dark number because it actually means you're letting go. And just for the record, the fact that the positivity has been rising over the summer of 2020, 2021, sorry, well above what it was in 2020 is not necessarily good news. We can look at curves, but of course, I mentioned the United States a few times, and immediately then we say in one state something happens, but in another state it's completely different. I will return to that. Belgium is a small country, 11.5 million people, geographically fairly compact, and still, if we look on a not so randomly selected date, the 11th of November 2020, which is pretty much near the top of the fall wave, we see that in the north of the country, this positivity map colors relatively lightly, so you would have 10–15% positivity, which is too high, by the way. But in the south, in the French-speaking part of the country, it goes up to the range 25–50%, with some exceptions in the deep south, the less populated province of Luxembourg, for example. And this blip here is the capital city, Brussels, which is like in many countries, small geographically, but is more than 10% of the, or about 10% of the population. So it's a good question. How can this be if you have a single country and such a big difference, which is actually not volatile? You might say, okay, but now show me the graph 10 days later or 20 days later. This separation still stays. And it means, just as we see, for example, in the United States, that local policy, local public opinion, local sensitivity sometimes can have an impact on the way that the epidemic evolves. I'll talk a little more about the time lag in qualitative terms. Back to the dashboard, or back to the dials in the cockpit. We have here intensive care occupancy, and you may start to say, okay, all these graphs look more or less alike. Well, not entirely. There are subtle differences. We see the first wave, spring, second wave, fall of 2020. We do see slightly better in intensive care occupancy the blip in the summer of 2020. And then we see a long period where actually there is a decline and then a build up again, but where the number never really gets extremely low. And then we have a third wave in intensive care. And if I return for a moment, which we didn't see so much in the positivity, which we didn't see in the total number of cases, and actually not to the same extent in confirmed cases. And of course, there's a good reason for that, alpha and delta. Once we move into 2021, we have variants with the burden of disease higher than what it used to be. And then currently we are on the rise again, and we will see where that leads us to. But this graph goes to, let's say, the end of August, more or less. What it will be in October, November, and December, That's a subject of prediction or correction, maybe better to say scenario analysis, because what will happen is very difficult to predict if policies are not even set. And that's something we have to keep in mind. Statisticians, epidemiologists, methodologists can make predictions under a given scenario, and that's why we prefer to call it a scenario analysis, because it basically offers to policymakers a range of options, all with their advantages and disadvantages. And with all modesty, from an epidemiological and a biostatistical perspective, we can put a few cards on the table, but there are of course also economic cards, there are well-being cards, etc. And then yes, there is the mortality curve. I'll be brief about it, even though it's a very important one, but I plan to return to it near the end if there is time. There we see that unlike in the intensive care occupancy, the third wave is not so clearly present, fortunately, in the mortality, which has to do with, in spite of the characteristics of the predominantly alpha variant. And why is that? Well, that has to do, of course, with the progress of the vaccination campaign. Talking about the variants, this is a segment of the incidence curve. Now, I showed a number of cases. I haven't actually talked about incidence, shame on me, but by that we mean here, because there are several definitions, of course, the number of cases over a 14-day period per 100,000 inhabitants. Now, the blue and the green curve are, for our purposes, not so important to distinguish between. The blue curve is the Belgian incidence for the entire population, full stop. The green curve is for the north of the country. And even though you saw earlier that there were big differences between the north and the south, true, but not across the entire pandemic. This was really very explicitly present in the fall season of 2020. Here we're talking 2021. And what we see is, and now this is what I wanted to point out, the red curve is actually the incidence in the northern, the Dutch-speaking school system of the country, where you see this sudden breakthrough of the curve. It hadn't been there since the beginning of the previous school year, suddenly a breakthrough with the rollout of the alpha variant, which affected schools differentially relative to the population and relative to what it was before. Which of course means that difficult conversations have to start with all authorities. For example, you have to intervene in the extra scholarly activities. That's what we did. And we were able to stop the rapid increase and get the curve more or less, but sometimes less than more, in sync with the rest of the population. This goes until the end of, well, April, beginning of May 2021. The evolution continued like that until the end of the school year. But the question today is, where are we now with the start of the new school year and with the Delta rather than the Alpha variant? When I stop here on the 7th of May 2021, this is the period prior to the, not arrival, but prior to the significant rise of the Delta variant. This is a similar figure, but then actually for the personnel, for the staff, so the teachers, but all staff in the school system, but also in higher education, my sector and also the sector for several other people around the table. The red curve is the incidence over the period from the beginning of January to mid-April, roughly speaking, of 2021. The red curve is the evolution in higher education personnel. The green curve in compulsory education. And then the dashed and the dotted lines are respectively the general population and the entire workforce. So you see, for example, that the green line again, which is school teachers, so to speak, are for longer periods not just above the general population, which is normal. There are many people in the population who don't work, retirees, people who are not working because their sector is closed, also young children, etc., but also across or over the rest of the workforce, which has to do with the exposure, of course, in the school environment. In the healthcare workers, we have a very interesting evolution. At the top, we see the vaccination coverage. And of course, I don't need to tell you that this is over the period just the end of 2020 until the end of March, beginning of April 2021. The green curve is the rapid vaccination curve in the healthcare workers in the country. We started a little later with the healthcare workers in the hospitals, and then you also see the evolution here. And below, this is actually mirrored almost with the evolution of the incidence. So you see a little after the vaccination campaign has caught on in the healthcare workers, whatever of the two sectors you look at, then the incidence really rapidly goes down. It took a little longer in the healthcare workers in hospitals, and so it seems that it's working a little less there, but we have to view this against the background of curves increasing in many sectors. We saw it a moment ago in the educational system, which was not prioritized in Belgium. And against that background, you have a decline versus an increase in other sectors. A curve that is a bit, well, eclectic, jittery, a bit chaotic almost, is the so-called increment curve. And of course, this is not a curve that is very suitable for general public communication, because it's literally a curve derived from another one. And that other curve is the incidence curve. So what we look at here is how the incidence in the current week has evolved relative to the week before. Now you can say, you can look at the reproduction number, and it's absolutely true. You can also look at the reproduction number. But this curve tends to be a little stabler, especially over time frames where the epidemic is not so big, has shrunken to small numbers. Now, unfortunately, over the period we are considering here, from the 1st of September until a week ago, we were never short of cases. What you see is a curve that, if it's negative, we see a decrease in the actual incidence curve. So basically the derivative is negative. That's a way to think about it. If it's positive, we have an increase. So if we go back to September and October of 2020, we see a period of ever more rapid increase. Well, if the increase increases, that points, of course, to exponential evolution. But then the system cools down and the increase gets smaller and smaller and smaller, but never stops increasing. That's something we have to keep in mind, and then starts increasing again. What we now, and of course, you say, okay, in a country like Belgium, schools start, oops, that's too quick. Schools start on the 1st of September. Okay, this must be the schools. But of course, we all know that in epidemiology, we have to be very careful. It's not because two things evolve more or less at the same time that, or in the same way, that they are necessarily causally related. We now know, and I can talk about it more, but I will not go into details, that this is predominantly seeding from people returning from abroad. We see that in many countries. Already in the summer of 2020, we had good data from several other European countries like Germany and the Netherlands, where really a very large fraction of the cases confirmed in late summer vacation was traceable to introduction from abroad. And we looked in particular at Spain for that reason, because not just biostatistical or epidemiological evidence, but also sequencing information has confirmed that actually later. And of course, if it's travel, then that's going to stop. At one point, travel goes down to the trickle that it usually is in the fall relative to holiday seasons. And then we have a rapid increase again. So if it would be schools, the school system is continually open, you would expect a more gentle evolution, but not this yo-yo effect. But what happens in the middle of September, beginning of October, the impact of higher education, which starts several weeks later in Belgium than compulsory education. And that these two phenomena together actually led to a considerable peak in the second wave, where we confirmed between 20,000 and 25,000 cases a day, and the number of beds taken in intensive care rose to 1,471 2024, which for a country of 11.5 million people is considerable. Mortality over the year 2020 rose to about 20,000. Severe measures were taken, second lockdown in the fall, but still not with the same stringency as it was in the spring of 2020. And then you see that for the first time in a long time, this leads to a decline with an upshot and then another decline. And then we go into a long period of yo-yoing between, well, this is the plateau phase with roughly 2,000 cases a day. Where you go up for a while and then people start worrying about a little bit. That means measures have to be taken, or just people adapt their behavior automatically. It goes down again and then up again. And in this period here, you see that actually increase wins over decrease, and that's when the third wave happens. Delta catches on. Vaccination, in contrast, also catches on, and you see a longer period where actually decrease is dominant, apart from a few peaks. And then the beginning of summer, this has to do with what we call slightly too early relaxations of measures. You see this long period again of increase again. We've had that until late August, and just now, recently, we have seen a slight decrease, which is turning around into an increase again. So the yo-yoing effect is still ongoing. What I show here is the evolution of our hospitalizations, but in a very peculiar way. This is a technique developed by colleagues Crystal Faas, Neil Hens, and a few others. On the horizontal axis, we have the new hospitalizations on a given day. And on the vertical axis, we actually have the evolution of that same metric. And of course, you want to be in the lower left corner. That's few hospitalizations and a decline. Of course, if it's zero, it cannot keep declining. You would basically end up here, and zero. That's where you would like to be. But this is the trajectory that we follow from September 2020. So this period here, the trajectory where we move gradually more into the red, and that's where you really don't want to be until there is that improvement, and then a long period of basically almost Brownian motion going up and down and left and right, but not really changing all that much. And this is a reboot where we start again on the 1st of the 1st of June of 2021 for the current year. And again, we have this evolution until now. It stops on the 10th of September, so roughly 2 weeks ago. Okay, of course, we have our focus. We've had our focus so far on 2020, but if we go 1 century back, we know that there are lessons to be learned. And for those people who have studied the history of the Spanish flu, part of it says, hey, this was a completely different time frame. And another part says, nothing has changed. It's still the same as what it used to be. Think of social distancing, stay in place orders, masks of all sorts and forms, just as we did actually in the late Middle Ages and the new era. Discussions that we had around the world, and you all can reflect on what it has been in your country in 2020, more recently, etc. Should schools be open or closed? Well, a lesson learned from, for example, the American system during the Spanish flu pandemic is in areas where there were somewhat more difficult to reach populations, actually keeping the schools open. And remember that in the Spanish flu, young people could also be severely affected, had a beneficial impact, not just on them, but also on the population as a whole, because through the children, health and hygienic messages could be passed on to the children. No silver bullet. We know that there are advantages and disadvantages to everything. But for example, in the Lower East Side of Manhattan, you had a large immigrant community, predominantly Italian, and there were a lot of victims, of course, in such communities, immigrant communities, labor communities, etc. Whereas if you went to Fifth Avenue, or for those from France, to Boulevard Haussmann in Paris, just to give an example, people were relatively lightly hit because the hygienic circumstances are just better. And well, social distance in a mansion on Fifth Avenue is a little easier than in the crowded tenements on the Lower East Side of Manhattan, except for the labor force, so the cooks and the house personnel. That was a different thing. Still to this day, whether you study the TB pandemic or COVID-19 right now, the socioeconomic element should not be underestimated. And yes, that actually means that if you look around during the last 1.5 years to almost 2 years right now, and you'd ask which groups are now the driving, or which group has been the driving force throughout, there's no answer to that, because it really changes with time. Let's go back to January, February 2020. Who has carried around the world? Well, I should say people like me, for example, meaning world travelers, people who for business reasons, for academic reasons, for whatever reasons, diplomatic reasons, travel around the world. How was that, by the way, in 1918? Same thing. The seafarers, the freight lines on the one hand, and then, of course, very specific for that time bracket, the military. Comes February, March 2020, here in Europe, we kind of refer to the skiing season, with then typically the après-ski bars in Austria, etc. But of course, around the globe, think, for example, also United States, but also Europe, Latin America, the carnival season. And if you look at the spread, based on phylogenetic analysis, the spread of the virus around the United States, for example, you do see that the carnival cities did play an important role as well. Same in Europe. In the north of Belgium, by the way, in the south of the Netherlands, in the west of Germany, etc. So if we go beyond that, and we now move into the summer of 2020, you have two other groups. First of all, the vacationers, people in the middle class and also higher sometimes, who go to the sometimes fancy vacation spots, Côte d'Azur, but also Spain, around the Mediterranean. You have equivalents around the world. You can take Mexico, for example, also. And then people, labor migrants, who go back to their country of origin, whether or not there are travel bans. That's for certain groups not such an important barrier. If you have dual nationality, it's very difficult, of course, to stop people from traveling. And then in the major cities in the world, we see that comes the summer of 2020, we actually have a lot of circulation there, and it's actually in some of these cities that vaccine development has taken place. If we look into the fall of 2020, we see in Belgium, predominantly in the French-speaking part of the country, and that's part of the explanation why my 11th of November map with the positivity, remember, was so deep red in the south and somewhat more yellow in the north. The higher education system. And in Belgium, we have something a little peculiar. It's not absent in other countries, but it's an art form almost in Belgium. If you're a university or a high school student, during weekdays, you live in the university town, like Brussels or Louvain-la-Neuve or Leuven or Ghent, etc., Liège. During the weekends, you go home and you take part in the social life in your family and in your social circle in your hometown. And of course, you can. This is basically almost like the fan going around and spreading the pandemic around the country. We are quite sure that this has had a significant effect on the spread of the pandemic. And I'm not using the word significant here figuratively speaking or loosely speaking. I do mean in the statistical sense, because over and above many other factors for which correction has been made, the fraction of high school students in a town in the fall of 2020 was an important predictor for the pandemic, in as much that during the summer of 2020, it was more, let's say, the popular neighborhoods, the densely populated inner cities, Brussels, etc., that showed high incidences, relatively speaking. In the fall, it was actually the other way around. Often well-to-do but rural areas got more infected. If we then go to 2021, I can suffice by saying, well, there are differences, but some of the dynamics are playing to this day in exactly the same way as before. So I talked about statistical analysis modeling, a model that has been used, and there are many of those, a compartmental model by the colleagues like Neil Hens, Steven Abrahams, many others. Is as follows. You have you basically move through the compartments, and all of these movements are described by appropriate differential equations. There is a stochastic component put on the model, and that is then numerically solved with Bayesian methods to get a feel for what's happening and also for what's going to happen under given scenarios. A model like this, the way it's used in our institute, is informed by data, and these data come from various angles: contact information, vaccination, the immunity, so the seroprevalence build-up in the population, etc., etc. Of course, in the meantime, we have variants and we have various vaccines. So that means the picture I'm showing here should basically be repeated 5, 10, 20 times, depending on how many strata there are. So it's become quite complex in the meantime. We all set out in the susceptible group, and even that may be a bit of an approximation, because there may be people who were not even susceptible in the beginning, perhaps after a recent infection with another coronavirus. But let's not go into detail on that front. So you get exposed to the virus, then move to the pre-symptomatic compartment, and there the track has a switch. You can go to the asymptomatic fraction, stay there and recover, and it's the end of the line for you. Or you go in the mild compartment, and then there is another switch. You can recover from there. You are mild, you remain mild, coldish, mild flu, that's it. Or you can develop a more severe version that can require either hospitalization as such, or hospitalization with, in addition, surgery in ICU, from which you either recover or die. It's a bit of a simplification, because it's perfectly possible that people never made it to hospital and die. That's actually in the model also taken into account. How could that be? Well, for example, in nursing homes, many people died there without going to a hospital. And that this is an important fraction is clear from the fact that in 2020 in Belgium, 55% of the deaths actually were nursing home residents. And in the first part of the pandemic, so spring of 2020, this was even 2/3 of the deaths were realized in the nursing home population, which, by the way, is 300,000 people out of a total population of 11.5 million. Needless to say that with a very contagious virus and the fact that there is unfortunately somewhat higher infection fatality rate than we would like, it is natural to consider measures, to consider interventions. But if you don't have pharmaceutical interventions, what can you do? We already referred to 1918. Face masks, distance, stay in place, perimeters, all sorts of things. So ventilation, other hygienic measures. And the goal is very simple, to make sure that rather than realizing a curve like this, it becomes the solid curve, so that perhaps with an expanding capacity in healthcare, you manage to stay below capacity rather than exceeding it. And this can be hit and miss. We know that very well, because if we look around the globe, we know that in many countries and in many areas for certain points in time, it almost didn't work. And by that I mean there had to be emergency scaling up measures taken for hospital, especially intensive care capacity, oxygen, etc. And in some cases, that didn't work or didn't suffice, and people didn't get the hospital care they should have had. Nothing new under the sun, because in 1918 we have a very similar curves, but these are not theoretical curves, they're actual curves. Now expressed in terms of mortality. This is Philadelphia. In Philadelphia, in October, late September, October 1918, army contingents were preparing for the trip to Europe, the end of World War I. There was a big parade, because that parade was actually a fundraiser, and even though the epidemic was in the city and people knew that, they thought it would all be okay, and the parade was so important for morale and for money making, and this is the consequence. St. Louis saw it all happen on the coast, took measures, and San Francisco is the same story, took measures very early on, and the result is, of course, what we sometimes call the prevention paradox. Hey, we take draconic measures, nothing happens. Or prevention paradox, or the self-defeating prophecy, of course. That's something we struggle with all the time, but that's, of course, the way you want it to be. Let's flip forward again to the current century. Here we see the curves of a number of cities in Belgium. And well, your familiarity with Belgium may be more or less, but it doesn't matter. Let me just single out this blue curve here for the city of Antwerp for various reasons, and not really because I was born there, there's nothing to do with it, but look how it sets itself apart very quickly near the, it's not very visible here, but near the end of June, we see a real very rapid rise in the city of Antwerp, and what is going to be like Mount Everest then suddenly stops in its tracks and becomes something that resembles a bit more Table Mountain, and then comes down again and joins the rest of the pack again. What happened? This is the one very dramatic occasion where regional measures were taken, including a curfew, one of the measures that I did not mention yet. And in terms of policy making, that's been an interesting case. I had the opportunity to be part of the process when it happened. And of course, people were asking the evidence, and many were thinking like randomized clinical trial type evidence or randomized experiment evidence at least. But how are you going to provide that on the spot when taking a decision is urgent? And in the Western world, there really haven't been all that many curfews since World War II, maybe except for, let's say, terrorist attacks, etc., for a short period of time. So some of the evidence you build on the fly, and you apply the asymmetric risk assessment principle. If it's not going to work, well, too bad, but we have tried it, and for a short period of time the damage may be under control. If it would work and you don't apply it, that's a very different method. And it worked, but of course, like ever so often, measures were not stringent enough in other areas, were loosened too quickly in Antwerp, and we started building up our second wave. What was the European situation in the summer, late summer in 2020? Well, we have the incidence here ranked in terms of severity in a number of European countries. Luxembourg is a bit of a special one, but you know Luxembourg is a very small country, and they had done a very extensive testing campaign, and that's why it's relatively high. But the winner was actually, other than that, Spain, and we weren't doing so great either. Even though in certain countries, especially countries in the north and in the east, incidents were terribly low. Hungary too, for example, and that's a value that is unheard of in many countries, even though, for example, in Israel, we realized that as recent as June 2021, sorry, but we know that the incidence now in Israel exceeds 1,300. So indeed, what is it now? The fact that Belgium here is in the first position is not because we are worse, because this table is ordered alphabetically, just to give you a bit of a flavor. You don't see all that many countries with one-digit numbers. They're there, they're still there, but they're running thin right now. But I mentioned Israel. This is a bit over a week old. 1375. It's not very different from that now. Kosovo, in the meantime, has gone down below 1,000, but the United Kingdom still is at 724, United States 662. Both countries are declining right now. India at a very severe wave in the spring. The incidence currently is quite a bit lower, but of course, in many countries, we have to take into account that the confirmation rate is much lower than in other countries. But by and large, we see too many three-digit incidences to be good. Of course, we are in a time frame where in many countries the impression is, well, incidences are becoming less important because of vaccination. We really need to look at hospitalization. Well, we know for Belgium, for example, if the incidence would double, so if the number of confirmed cases would double, hospitalization increases with 40%. In the UK, through the buildup of the Delta wave, that same number was 50% as opposed to 70% in the winter time of the previous winter. So talking about the United Kingdom, that's indeed what we have here. We, like in many other countries and also in Belgium, the spring of 2020 showed a very dramatic peak, but just not in the confirmed cases. We have the fall wave, and then immediately followed by, the fall wave was still the Wuhan strain, so to speak, but then we had the alpha wave that started immediately after that, and that's what we've seen in many places in the meantime, of course. If a wave starts before the previous wave has been touching down on the ground, you get very dramatic numbers, like up to 60, 70,000 cases a day, which after a long period of lower numbers, from the 1st of May 2021, more or less, started to rise again to a pretty elevated peak, but admittedly with much lower hospitalization numbers than before, about 1/4 to 1/3 of what it used to be. Then came Freedom Day. That's the narrative we sometimes hear, and the numbers started to go down. But if you look carefully, numbers were going down before Freedom Day. After Freedom Day, they kept going down for a short while, but then 10 days later, they started to rise again, only now to show a decline once more. I'm rounding off by looking at a few other countries around the world, and then I think there is time for questions. The Netherlands, our northern neighbors, they actually opened by the end of June, when the numbers were really very good. Their incidence had gone down below 100, so 2-digit. They opened nightlife, and a number of other measures were alleviated. And in an extremely rapid period of time, their incidence, actually in a week's time, the incidence multiplied by a factor 8. They intervened very rapidly, and by doing that, the impact on hospitalizations and mortality was kept under control, but it's not unnoticed. So we all know that there still is a link between the two. And I can go on like that. We see that in spite of vaccinations, the cases can shoot up, and in some cases, there are several states in the United States where that's happening. This can lead to intensive care occupancy or just hospitalization at levels that were never seen before. That's especially true in states in the US, for example, where until now things have been kept under control. And that's definitely not the case everywhere, but in a number of places, yes. So to conclude here, I think a useful way to look at Delta, because indeed an often heard measure or message is, well, the vaccination rate is so high, shouldn't we call it a day? Well, if you do a thought experiment and you take an infinitely large population and you start with 4 people with seasonal flu, and you let them infect other people, and these infect other people again, one generation after the other, and you go 10 generations down the line, you end up with something like 700 infections. If you do this with the original Wuhan strains of SARS-CoV-2, you would, after 10 generations, and it would take a little longer, but you would get to 350,000 cases, which is considerably different. But if you would let the Delta variant with its basic reproduction number, which of course we don't let happen and we cannot let happen anymore, fortunately, but if you would do that with the Delta strain, you would end up with 5 billion people, showing the extreme force. Fortunately, we have good vaccines, but just as well, because we have seen that in countries where there is no or little vaccine rollout, and with Delta arriving, the situation may be dramatic. So to leave sufficient time for questions, I suggest that I stop here, Mark.
Great.
Thank you, Geert. Thank you very much. We've had a few questions, so why don't I start with the first? And actually, my colleague Everardo Sad will help me with the questions that are more medical, and I will try and take the statistical ones in case there are any medical questions. Everardo, would you want to take the first question?
Yes. Hello, everyone, and thanks a lot for the presentation, Geert. We have some questions from the audience. One is, this is more statistical, were there differences in the increment function between the three regions, Flanders, Brussels, and Wallonia, the three Belgian regions?
Yes, it's a very good question, and actually it's not so well studied for the summer, for example, of 2020, but for the recent period, yes. And what we see in the three regions of Belgium over the summer, so let's say June until August of 2020, is that the increment curve, but actually so the incidence also, but actually also hospitalizations, is predictable by two extremely important predictors, and very well predictable, with R squares well above 90%. That is one, vaccination rate, and to be precise, the inverse of vaccination rate, which you also see if you look at, for example, the infection rates in American states versus the vaccination. You also see that 1/over relationship. And then second, the influx of returning travelers. So over the tourist season, the summer season, the travel season, these two factors explain it almost entirely. Now, in Brussels, for example, if we standardize this measure and we say, okay, how many people enter a country per 100 inhabitants, or a region, sorry. In Brussels, in the peak period, so late August, that would be 6 people per 100. Whereas in Flanders and Wallonia, so the north and the south of the country, it would be more something like between 2 and 3. So there is an enormous difference in influx. But then the vaccination rates to date are very different. Flanders and Wallonia had very similar vaccination rates for a large part of summer, at least if you look at full vaccination. Now it's differential, and it's in rounded figures, something like 80% for Flanders, 70% for Wallonia, and 50% for Brussels. And therefore, the increment, the evolution is right now very different for the three regions, up to the point where for an extended period of time, we had a decrease in the Flemish part of the country, so the north, and then an increase in Brussels and more of a steady state in Wallonia. Now that's actually reverted to Brussels, we think, temporarily declining, and Wallonia fairly rapidly increasing. So yeah, it's basically like boiling water. Huh? There it goes up, but in another place it comes down. But we do have a good sense for why this is happening.
Okay, I have a question of my own that relates to your answer. When we hear coverage rates for vaccination, is this for eligible people, or is this on the denominator is the population?
Very good question. I tend to look at the entire population, and the figures are definitely for the entire population. And some people say, hey, that's not fair, because, for example, right now 0 to 11, cannot be vaccinated yet, even though there is evolution and there is news from the previous days. True, but the thing is, if you look at it epidemiologically, all people are part of the system. For example, there was a time when vaccination was restricted to 18 plus. And then, of course, you can say, okay, even if we reach 100%, if you look at the population as a whole, you may not even go to 80% because there's just a large number of people below 18. And that's true. So you need to think very carefully how you communicate this. Because if the general population has the feeling that 70% of vaccination is enough, but you really mean against the population as a whole, because the 16 and the 17-year-old, and again, now they can be vaccinated, but they couldn't at a certain point in time, they do participate in life, and often abundantly so. So that's why I think it's important, but this goes back to the beginning of my presentation, all dials in the cockpit, both numbers are important. And in a conversation like this, I'm happy to quote one and the other. So for Flanders, 80%, if you look at the entire population, it's more like 90% if you look at eligible people. Okay, we can deal with that. But for public communication, you really have to carefully think which numbers you are going to use to avoid any misconception.
Very good. Mark, we have another question here, I guess. Shall you want to go ahead and ask it?
No, go ahead.
Okay. Yes, so it's mixture of a question and a comment for Geert. Looks that the effect of the vaccine does not last forever, right?
Mm-hmm. Yeah, that's true. Even again today, there was again news from J&J what the second dose does, and a journalist was asking, see, they said one dose was enough, but now he actually took it, he or she took it as negative news. But of course, nobody ever said that this would last forever. And I think we know very well with influenza, with the seasonal flu, it doesn't last forever. And there are many reasons for that. There is just a natural biological process of waning immunity. And at the same time, there's the natural biological process in the virus. And for flu, we know it mutates more or less as you speak. It's a little less so for coronaviruses. They are fairly stable. But of course, if you have a population of billions and billions of hosts and you let it, let's say, generously circulate, of course, you're going to see mutations. So all of that is learning as we go. And in a way, the phase 4 trial, so the post-marketing studies are experiments in the population as a whole. We learn as we go. It doesn't last forever, no. And that's why country after country decisions are taken for third doses in fairly general populations in some countries, in other countries not yet, in yet other countries in restrictive populations. And we are now at the level that the people who are immunodepressed, they're being invited. People in nursing homes will soon get their third dose. And we are now going to the elderly population very likely as well.
Okay.
Here, I've got another question at the other end of the spectrum. You mentioned teenagers. What is your opinion about vaccination of teenagers or even younger children?
Yeah. Well, first of all, that it's a very heated debate. But of course, the proof of the pudding lies in the eating. I'll come out and say that I'm actually in favor, but I do understand that there are concerns. When we started talking about vaccination of the 12 to 15, the debate became suddenly extremely heated. And even in the broad medical profession, I've always observed that there are very different opinions. If you talk to, let's say, vaccinologists or infectiologists or GPs or pediatricians, you get different perspective, and that's only natural. Interestingly enough, 16 to 17 poses no questions. It's not any more or less emotional than 18 to 19, but suddenly 12 to 15 was. And I think we can understand that. But if we look at the numbers in Flanders, So the north of Belgium, 85% of the age bracket 12 to 17 taken as a whole is at least partially vaccinated and ripening as we go. Now the discussion is already starting for the 5 or 6 to 11. And even today, this very day, I had a conversation with two different medical doctors from two different professions. And one was actually fairly strongly against. And the other one said, the second one was a GP. And he said, what strategy should we follow to have this done as soon and as quick as possible? And what should we do to get the approval, etc.? So again, the debate is starting, but it just follows the general feel in a population, the general perspective, the general reluctance or acceptance of vaccination. We see very big differences between the north and the south, and there are, of course, cultural components. We know that the south of Belgium, French-speaking, often looks at France for important aspects, and France for a long time had a very low vaccination rate. But of course, between mid-July and mid-August in France, it has increased by 15%, and in certain departments like Saint-Saint-Denis, it's gone up from 50 to 70% indeed. The champion at this point in Europe is we Flemish people like to think that we're the champion, but no longer. The Portuguese are ahead of us. There's 85%, actually 87% of the Portuguese population that is vaccinated, even though they start at 12, and of course also they have not started yet at 6 to 11. So it depends on a number of factors indeed. But I think given the very strong force of the Delta variant, that it would be very welcome to all, and also for their own benefit, to have the 6 to 11 part of the vaccination campaign. But I do realize immediately, and I acknowledge and I have a lot of respect for the fact that there is a variety of opinions here, and that we have to approach this extremely carefully. So a lot of, I think this is a very important discussion, and we should not railroad it through. We should do it properly, profoundly, but at the same time, there is no time to lose. So that's what they call a pandemic.
Well, thank you so much. I see that we are on the top of the hour, so I'm afraid that other questions will have to be answered by email, but thanks again for your very nice presentation here. I think we have to wrap it up. Kelsey?
Yeah, thank you so much, everyone. And just a quick note for the audience, if we couldn't attend to your questions, we'll be sure to follow up with your questions after this presentation. And if you do have any further questions, you can direct them to info@iddi.com. And thank you everyone for participating in today's webinar. You'll also receive a follow-up email from us with access to the recorded archive for this event. And you'll also receive a survey window right after the webinar is closed. So we'd really appreciate your participation in that. It really helps us improve our future webinars down the road. And just a final thank you to our speaker, Professor Molenbergs. We really appreciate your insightful presentation. Thank you everyone for participating today. Have a great rest of your day.
Thank you very much.
Thank you. Bye-bye.